So this child, the first question in pediatrics, this child has actually a hairy pinna, and hairy pinna is classically seen in infants of diabetics. So it is seen in infants of diabetic mothers. And if you look at the most common cardiac anomaly in infants of diabetic mothers, it's a ventricular septal defect. So remember, the most common cardiac anomaly in infants of diabetics is a VSD. Now the next question is on what is the common sequence of congenital heart disease according to frequency, and according to the Nelson's textbook, the answer is third. The most common congenital heart disease is ventricular septal defect, followed by ASD, followed by coarctation and TGA. So remember, almost 30 to 35% of all congenital heart disorders is a VSD. Atrial septal defect is seen in around 6 to 8% of all the congenital heart defects are atrial septal defect, followed by again PDA. PDA is also seen in around 6 to 8% of these babies, and followed by these coarctation of aorta, which is quite rare. In around 5 to 7% of babies would have a coarctation. TGA is a very rare anomaly overall, seen in around 3 to 5% of babies worldwide. But remember, TGA will be the most common cyanotic heart disease to present during infancy. So remember, during infancy, the most common cyanotic heart disease to present would be a TGA. And beyond infancy, the most common cyanotic heart disease is a tetralogy of Fallot. Coming to the next question, and which is about which of the following is not a risk factor for recurrence in febrile seizures. Let me see. It's about epilepsy. So this is a very common question and has been asked in All India PG also before in 2010. And remember that onset before the first year of life. Onset before the first year of life is not a risk factor for epilepsy. Okay, so remember, onset before first year of life is a risk factor for recurrence. So in fact, it is a very major risk factor for recurrence, but it is not a risk factor for epilepsy. So when we talk about epilepsy in febrile seizures later in life, the most important would be that remember, a simple febrile seizure, the risk is just 1%. But if it is a recurrent febrile seizure, the risk is around 4%. If this child has a complex febrile seizure, this child has complex which is lasting more than 15 minutes, then the risk is around 6%. Within 1 hour, if he gets fever and he gets a seizure within 1 hour, the risk is around 11%. In family history, the risk is around 18%. Remember, and especially when a patient has neurodevelopmental abnormalities. Neurodevelopmental abnormalities, the risk is 39%. So this is most important. They have asked before, what do you think if a patient has mental retardation, what would be the risk of recurrence? So it will be 33%. Remember, the drug of choice for febrile seizures, the drug of choice would be a per-rectal diazepam. So the treatment of choice for treating febrile seizure would be a per-rectal diazepam. And the prophylaxis here, the prophylaxis which we commonly use is mostly an oral clobazam. So remember, the drug for prophylaxis is clobazam. It's an oral benzodiazepine called clobazam. Okay. Coming to the next question, which is on resuscitation and about intraosseous excess, which is the preferred bone used in babies in pediatric resuscitation, and the most common is obviously it is the anterior proximal tibia near the tibial tuberosity. So this is near the tibial tuberosity. Intraosseous excess, if you cannot get a venous excess within a minute of arrest and you cannot get a venous excess, you go for intraosseous excess, and we give anterior tibial near the tibial tuberosity. And remember, the next option would be you would give him normal saline bolus 20 ml per kg to treat the shock, which you'll give by intraosseous route. Okay? Okay. Now, question 5. This question is about the most common acquired heart disease. The most common acquired heart disease in children is Kawasaki's. So, especially in the developed world, the most common acquired heart disease is Kawasaki. And in the developing world, the most common acquired heart disease is rheumatic. Now, it rarely recurs. Only 1 to 3% of Kawasaki's recurs. Okay, so remember, Kawasaki recurs rarely. The drug of choice, because in Kawasaki's, almost 20 to 25% of these these children who are less than 5 years, they have a risk of getting coronary artery aneurysms. So remember, they have a risk of getting coronary artery aneurysm. Okay? Remember, 85% of these children are less than 5 years. So Kawasaki's is a disease of children. So to prevent these aneurysms, we give intravenous immunoglobulin 2 grams per kg. So we give intravenous immunoglobulin 2 grams per kg, by which the risk reduces to 4 to 6%. So initially the risk was, we said the risk initially was around 20 to 25%, and now I am saying the risk reduces to 4 to 6%. And along with this, I will give aspirin 100 milligrams per kg per day for 2 weeks. So aspirin is the high dose aspirin, 100 milligrams per kg per day for 2 weeks. It rarely recurs. 15% of times, Kawasaki can be resistant to immunoglobulins also. So 15% of the times, Kawasaki's is resistant to immunoglobulins, where you may give another dose of IVIG, or you may use even prednisolone in those patients. So remember, steroids otherwise have no role in Kawasaki's, but only in these patients you may give steroids if they are resistant. Now the next question was on RDS, which statement is not true. Now first of all, remember that CPAP is very important, even if they are not symptomatic. So currently the current edition, the 20th edition of Nelson's textbook says that this statement is true, that we should give CPAP, early CPAP support to these babies who are not able to maintain saturation. Okay, the second statement is a strategy in ventilation called permissive hypercapnia, where we keep the PCO2 on a higher side, and this is very important to maintain their respiratory drive. High frequency oscillatory ventilation is a new ventilatory strategy where we give very high rates of breath, like 300 breaths per minute, and it better recruits the alveoli, and there is a less risk of barotrauma in these patients. But remember, caffeine has no role in RDS. In severe RDS, of course, you'll give intratracheal surfactant. So caffeine is basically the drug of choice for apnea of prematurity. Okay, 20 milligrams per kg. Remember, caffeine is usually the drug of choice for apnea of prematurity. We give a bolus of caffeine around 20 milligrams per kg, followed by maintenance dose, which is 5 milligrams per kg of maintenance dose. So caffeine is basically to prevent further episodes of apnea in preterms. For apnea of prematurity, we give caffeine. Now this question is very important about the most common cause of sepsis in India, which has come in your exam multiple times. Of course, Neisseria doesn't cause any problem in newborns. Neisseria is after 2 months of life. So remember, the most common cause of sepsis all over the world in newborns, neonatal sepsis all over the world, is group B streptococci followed by E. coli. It's group B strep followed by E. coli. And the most common cause of sepsis in India is Staph aureus. So first of all, remember, it's Klebsiella followed by Staph aureus. So in India, it is Klebsiella followed by Staph aureus. This has been seen in a very big study done by All India Institute. So, followed by Pseudomonas. So, remember this Klebsiella followed by Staph aureus followed by Pseudomonas. Okay? So, this is very important. That in India it's Klebsiella followed by Staph aureus followed by Pseudomonas, comes in every All India exam of yours. The next question is about a child who is around less than 2 months, and he has a respiratory rate of 60 per minute. Okay, so he is less than 2 months and has a respiratory rate of 60 per minute. So it's important that this child is less than 2 months. So remember, less than 2 months, any tachypnea. So our cutoffs for respiratory rates are less than 2 months, 60 or more, 2 to 12 months, 50 or more, and 1 year to 5 years, 40 or more per minute. Now remember, less than 2 months, any tachypnea is severe pneumonia. But since this patient has no distress, this is not very severe, this is severe pneumonia. So remember, less than 2 months, any danger sign, any tachypnea will be severe pneumonia. Okay, and if he has danger signs like severe malnutrition, convulsions, so then we'll label it as very severe pneumonia. Okay. The next question is a spotter. This is you can see this patient has cafe au lait spots, and this is hips arrhythmia. So as you can see here, this patient has a chaotic pattern of high voltage slow waves. So this patient has a chaotic pattern of high voltage slow waves. Okay, hips arrhythmia, and these are cafe au lait spots which are seen in tuberous sclerosis. So remember, this is tuberous sclerosis. And remember, tuberous sclerosis babies can have infantile spasms later in their life. They can have infantile spasms. So this patient has infantile spasms or salam seizures. He has infantile or salam seizures. And especially for tuberous sclerosis babies, the drug of choice is vigabatrin. Otherwise, the drug of choice is ACTH. But for children with tuberous sclerosis, the drug of choice is vigabatrin, according to the US FDA. Okay. Now the next question is about a child who has nephrotic range proteinuria. We started him on prednisolone. Despite 2 weeks, he's still having proteinuria. So we'll continue prednisolone. Basically, we label a child as steroid resistant when he's not responding to 4 weeks. So we just call these children at 2 weeks, look for the response. Now, so remember, the definition of steroid resistance is basically no response to 2 milligram per kg 4 weeks therapy. So this is, we have just started prednisolone, so we'll not do anything. Our plan is to give him 6 weeks of daily therapy and 6 weeks of alternate day therapy. So all over the world nowadays in nephrotic syndrome, first episode, we treat them as 6 weeks of daily therapy and 6 weeks of alternate day therapy. So 6 weeks daily, 2 milligram per kg, and 6 weeks alternate day, 1.5 milligram per kg. Okay, so this patient surely has just a first episode nephrotic syndrome. I will not worry much about him. The next question is on malnutrition, and remember that in severe malnutrition, especially if you look at the B cells are reduced in the blood. The hypersensitivity reaction delayed type is also reduced in the blood. There are also complement abnormalities. They are also reduced in the blood, but the total T cell count is not affected. So remember, in malnutrition, the total T cell count is not affected. Similarly, total lymphocyte count, total leukocyte count, the CD4 count, the total immunoglobulins are also not affected. Okay. So remember, like I told you, B cells and complement responses are also reduced in these patients in malnutrition. The next question is clearly a case of acrodermatitis entropathica. So this patient has, as you can see here, this patient has periorificial dermatitis. He has periorificial dermatitis, and as you can see, they are like vesicobullous lesions, peculiarly, and they are usually periorificial. Remember, acrodermatitis entropathica can also be autosomal recessive. So it can be nutritional, it can also be autosomal recessive. Low zinc levels are seen, and surprisingly, yes, even low alkaline phosphatase levels are also seen, because alkaline phosphatase is a zinc dependent enzyme. So the treatment of choice is basically zinc therapy, and it is not 0.3, so this is wrong. It is not 0.3. The treatment of choice is zinc, 3 milligrams per kg per day of elemental zinc. So 3 milligram per kg per day of elemental zinc is given, and then we monitor the levels in these patients on a long term. Okay, remember, it can also be a genetic disorder because of a genetic defect in intestinal zinc transporter. There's an intestinal zinc transporter gene called SLC39A4. This gene is affected and can cause acrodermatitis entropathica in these children. Now this is a different question. This is not stranger anxiety. We are talking here about that separation anxiety, or which is also called rapprochement or separation anxiety, which is, according to the Nelson's textbook, is around 18 months. So remember, stranger anxiety is different, which is at around 7 months of life. Okay, so remember, this 7 months is basically stranger anxiety, when a child is scared about whenever he sees strangers. But this is separation, rapprochement, which is typically achieved at 18 months of life. Now, which neonatal seizure has the best prognosis? Whether it's, so first of all, talking about the etiology. Remember, the late onset hypocalcemic has the best prognosis. The late onset hypocalcemic seizure has the best prognosis. Now, if we look at the type, the focal clonic seizures have the best prognosis, and myoclonic seizures have the worst prognosis. So myoclonic have the worst prognosis, and focal clonic has the best prognosis. GTCS is not seen in newborns. Remember, I know some of you must be asking about GTCS. GTCS is rare in newborns. Okay, so remember, GTCS is rare in newborns. Now talking about milestones. So remember, tower of 2 is around 15 months, and then if we talk about tower of 6, it's around 21 months of life. Everyone knows about tower of 9. Tower of 9 is at around 3 years. But when can a child make a bridge of 3? So bridge of 3 is actually at 3 years. This is talking about bridge of 3. So bridge of 3 is actually at 3 years of life. Vertical horizontal lines a baby can make at 2 years. He can also feed himself with spoon. Okay. Of course, everyone knows about circle at 3 years, plus sign at 4 years, multiplication sign at 5 years, a triangle at 5 years. Okay. But a bridge of 3 cubes is at 3 years. Remember this. Now the next question is on a very rare type of CAH called 3-beta hydroxylase 3 beta hydroxysteroid dehydrogenase deficiency, and they always have ambiguous genitalia. So normal genitalia is never seen in these babies. Okay, so normal genitalia is never seen in these babies. So these babies will have glucocorticoid deficiency, will have mineralocorticoid deficiency, okay, and they can also have abnormal genitalia. So these levels, whether it's androstenedione or whether it's testosterone, these patients have low levels of testosterone, and even estradiol levels are low. But remember, the genitalia are always ambiguous in 3 beta deficiency, whether it's a male or a female. This is a classic case of absent radius, and whenever you have absent radius, think about syndromes like TAR. So think about TAR, which is thrombocytopenia with absent radius. But you should also think about syndromes like Holt-Oram, which is a familial ASD secundum. So you should also get an echocardiography in these patients where they may have absent radius also. And lastly, you should also think about Fanconi's anemias, which are congenital aplastic anemias. So congenital aplastic anemias can also have absent radius. Which dehydration is most dangerous, which we very commonly see in our hospitals, and especially now, first of all, I would like to tell you who becomes hypernatremic. Those who do not have free access to water. Infants, they cannot drink water without their mother's permission, so they are dependent on their mother. Similarly, even older patients, old men are also at risk of hypernatremia. Now hypernatremia is very bad because it is a very hyperosmolar state, and these patients can get cerebral edema. So hypernatremia is the worst, which can be commonly seen in extremes of ages because they don't have free access to water. Can also be seen in diabetes insipidus because of loss of free water. It is seen in diabetes insipidus. Our aim in the therapy is a slow fall of sodium. It should not be more than 12 milliequivalents in a day, or I can say 0.5 milliequivalent per hour, because otherwise you can get central pontine myelonesis. So we are trying to prevent central pontine myelonesis because these patients are already hyperosmolar. They have so many osmoles in the brain, and now these osmoles are already protecting their brain against brain cells shrinkage. Now suddenly if you reduce the sodium, they can get central pontine myelonesis. Now sometimes in our class we don't discuss to you about the management of UTI, especially in a child less than 1 year. So according to our Indian Society of Pediatric Nephrology guidelines, and in fact I am the current secretary of our Indian Society of Pediatric Nephrology, and what we recommend that any child who gets a first episode of UTI, you should get, if he is less than 1 year, we get all of these three: ultrasound plus DMSA plus a MCU. If this child is between 1 to 5 years, we get a ultrasound and DMSA. If any of these is abnormal, we'll get MCU. After 5 years, we will get only ultrasound. So remember, after 5 years, if a child comes to us with UTI, we'll just only get a ultrasound, and depending on that, we'll go for other tests. But before that, remember, this is first episode of UTI. For recurrent UTI, always do all. So for recurrent UTI, you always have to do all of the following investigations: ultrasound, DMSA, MCU, all. Now a preterm has jaundice on day 24 of life. So which means this is prolonged jaundice. Okay, this is not normal. Any jaundice which is persisting is not normal. This is not physiological. This is called persistent jaundice. which can occur in breast milk jaundice, which occurs after day 14 of life. Biliary atresia also presents later in life. And rarely other syndromes, like I would add here hypothyroidism is classic case of persistence of physiological jaundice. Then Krishna-Najar syndrome type 2, especially type 2. So Krishna-Najar type 2 can present as persistent jaundice. Then any bleed anywhere like cephal hematoma. So these bleeds can also cause a persistence of jaundice, because you know from hemoglobin you get bilirubin. So if you have any doubts, you can email me. My name is Siddharth Sethi. I'm a pediatric nephrologist. This is my email address, sidsdoc@gmail.com, or you can tag me on Facebook on pediatric.nephrology. All the best and thank you.